Good afternoon, everyone. It's a pleasure to be able to provide an introduction to the Barts CTU before I hand over to our two speakers. So to follow on nicely from Beth's introduction, the Barts CTU also gained UK CRC registration in 2007, and the unit and its remit has evolved since then. We currently have 15 staff and continue to grow with a further 5 posts coming. The ACT programme, Advancing Substantial Improvements in Health Through Optimally Designed Clinical Trials, is a trials infrastructure grant which funds a number of core posts, including my own. The programme aims to provide a central platform for trials expertise with use of innovative methodologies for trial design to develop and deliver high-quality clinical trials across the centre, which will have a positive health impact. In my role as Head of Clinical Trial Management, I will oversee the ACT programme and support senior staff across the centre to make sure that the strategic aims and objectives are met. The Barts CTU has close collaborations with other centres within the Wolfson Institute of Population Health, with a long-standing core portfolio in cancer prevention, and also new links with disease areas such as preventive neurology, infection and smoking prevention. ACT funding also allows the Barts CTU to provide support to other units within Queen Mary University of London via a hub-and-spoke model. Support of the Cardiovascular CTU and Experimental Medicine and Rheumatology CTU in the William Harvey Research Institute has demonstrated a successful cross-institutional collaboration and aided these subunits to secure significant grants to execute high-profile clinical trials, leading to prominent publications in their respective fields. The cancer prevention trials portfolio, as I mentioned, currently consists of over 10 studies and includes prostate, cervical, ovarian, lung and breast cancer, as well as some cancer genetic testing studies. Finally, as a joint initiative led by the Barts CTU and Pragmatic CTU, we have started a series of trial management forums, which aims to bring together different trials groups across the whole of QMUL to share knowledge and best practice in trial management, to troubleshoot common issues, and ultimately to harmonise processes. We had our first meeting in June, and we used that to gather topics and ideas for future meetings, including governance, operations, and career development and training. Positively, we got very strong feedback, which supported future face-to-face meetings because trialists want those face-to-face interactions. And I'll take the opportunity to highlight that our next forum is on Tuesday, the 3rd of October, and we will be distributing more information about that to follow, and we do welcome everyone to attend. Hopefully that provides a brief but clear introduction to the Barts CTU, and I would like to hand over to Rhiannon for the first of our 2 presentations on the Yorkshire lung screening trial. Thank you, Rhiannon.
Thanks very much, Laura. So the Yorkshire Lung Screening Trial, or YLST as I might tend to call it for short, is a large ongoing community-based implementation study in the UK. It was initiated amongst growing evidence of a benefit for low-dose CT screening for lung cancer in a population at risk. The international evidence from 2 large randomised trials, first the US National Lung Screening Trial in 2011, and then more recently with the European Nelson trial, both suggesting an approximate 20% reduction in lung cancer mortality with this intervention. This remains the case as well when added together in meta-analyses of several smaller studies, including the UK lung screening trial, which was designed by Stephen Duffy here in the Wolfson. And we reported on that this year. So when we were planning YLST in 2016, we already knew about this 20% reduction in lung cancer mortality from the US. And in fact, the US had implemented screening following that with an update of their guidelines. However, we were still quite far from a policy change in the UK, and there were outstanding research questions, such as how do we identify the optimal population at risk? And following on from that, how do we encourage them to attend? So in 2000, our research questions are based around that, with research funding from Yorkshire Cancer Research in 2018, we initiated our implementation study. It's almost 90,000 people involved in this. We have 3 screening rounds over 6 years. So the intervention is an invitation to a free lung health check delivered on mobile vans in accessible community locations such as supermarket car parks. It's taking place in the city of Leeds, which has areas of high deprivation and high lung cancer mortality. And the first step to participation is telephoning the number on the invitation to speak to our team who check eligibility, and then for people who are eligible, they make the lung health check appointments on the vans. So this lung health check model puts less emphasis on words like cancer and screening that might otherwise invoke anxiety and deter participation. And these methods are based on behavioural science and the pioneering work of our very own Sammy Quaife and Stephen Duffy through their UK lung screen uptake trial. So the primary objectives of YLST centre around participation, prospective evaluation of 3 different risk criteria, and we're also looking at lung cancer outcomes over time in terms of advanced stage of disease, which is highly correlated to lung cancer mortality. We've also got a host of interesting secondary outcomes and ancillary research, but today we're going to focus on the results from the first round in terms of participation for telephone response and the attendance on the vans. So in individuals aged 55 to 80 with a smoking history who are identified from primary care records, further checks were undertaken, for example, to exclude people who had already had lung cancer or a recent chest CT. Those remaining were then randomised by household to either an invitation to a telephone call for a lung health check or to no invitation. So we've got a large trial involving almost 90,000 individuals, and we've analysed the data from the intervention arm in this green box here. And this excludes UK national data opt-outs and withdrawals after randomisation. So we can report that 51% of those sent an invitation rang our team and underwent the eligibility assessment. The calls took just a median of 4.1 minutes. 34% of those who called were deemed to be high risk and had an appointment made for them for a lung health check on the mobile van. Of those who were given an appointment on the van, 87% attended. Just over 2,000 people who attended were current smokers, and 89% of those accepted a referral for smoking cessation support. When we performed multivariable analysis to look at factors associated with telephone response, these are some of our main results here. What are these odds ratios telling us? Well, they're telling us that older people were more likely to respond and ring the telephone helpline. Males were less likely to respond. Those in the highest deprivation areas were less likely to respond. People classified as Asian ethnicity, according to GP records, were less likely to respond than white people. And we took GP smoking codes, read codes they're called, and we applied an algorithm that we wrote to these to try and identify people who were likely to be current smokers versus ex-smokers. And there's strong evidence here that the people classified as current smokers were less likely to ring the telephone helpline than those who were classified as ex-smokers. So overall, this is telling us that we do have a feasible approach to targeted lung cancer screening with our response rates, attendance, and practicalities around the telephone calls and acceptance, cessation support. However, further research is required to address uptake and inequalities in screening. This is very clear as well. Now, these findings were directly inputted into a report to the UK National Screening Committee. And in September 22, that committee recommended to our government that targeted lung health checks should be implemented across the UK. And then when I gave my presentation in June at the Turin conference for cancer screening, I was very fortunate that the day before, and that I spotted this as well, the Daily Telegraph had this headline, NHS lung cancer test for every smoker, which preceded by a matter of days Rishi Sunak announcing to the UK that we were going to indeed roll out lung cancer screening. And I really love this seemingly unrelated picture of the jockey here, because in terms of our intervention, it really is, yes, and we're off. We're now going to save thousands of lives. So we're really proud of our work and the impact that YLST has had to date. But there's more papers, and I'm behind on writing some of these up, including our second round participation. And also in our third round, we have this really important nested randomized trial of pathway navigation intervention in individuals who have not engaged with us so far. And that's being led by Sammy Quaife in our SPED centre. We've got these other outcomes that we're going to analyse and report on as well. And we've also been collaborating with other people in terms of participation in co-cancer screening, including the kidney and the bladder. And Peter Sassini's Cancer Prevention Trials Unit runs the Yorkshire bladder trial that we've collaborated with. And ultimately, YLST in about 2024 is going to morph into the NHS targeted lung health programme, which is currently being rolled out. So I don't think you can ask much more of that from an implementation study. So thank you really to all of our participants, our researchers and the wider lung cancer screening team in our institute. Thank you.
Thank you, Rhian, for that very interesting talk on a pivotal trial. I would now like to introduce our next presenters for our second talk. Adam, Senior Lecturer in Biostatistics, and Emily, a statistician within the Barts CTU, who will present an interesting talk on how to boost the power of your study.
Thank you. We've got a short presentation on an example of how we work with collaborators to help design effective studies. So, why should you work with a clinical trials unit? Because we can power up your study. A bit like Buzz here, Buzz Lightyear, except we don't say to infinity and beyond, because the sample size would be ridiculous. And mathematically, that makes no sense. Anyway, as you've already heard, clinical trial units are very important to ensure good conduct, governance, analysis, and many other aspects of running trials. The aim of our presentation is to give you a flavour of the role we can play in helping to design studies. Unless you're directly involved in trials, you might not see this process, because people usually present the results of a study where the design is fixed, and you just say, oh, that's the design, here are the results. So we're going to describe some designs we've considered for an ongoing study called Protector, led by Ranjit Manchanda and his team in the Centre for Screening, Prevention, Diagnosis, Detection. But the ongoing National Protector study enables women at high risk of ovarian cancer to access a new two-step operation designed to reduce their risk of ovarian cancer, as well as to avoid detrimental impact of an early menopause if they were to have ovaries and tubes taken out at the same time. It's implemented through a 42-centre national network within the NHS. The intervention involves removal of tubes, followed by delayed removals of ovaries near menopause. And the idea is to reduce the risk of ovarian cancer, but without the negative impact of symptoms associated with an early menopause. For this study, randomized allocation of different strategies is unethical and infeasible. And so women have a choice between not having surgery or having two different sorts of operation. As an aside, randomization is a cornerstone of much of evidence in healthcare, but you don't always need it in a trial, and sometimes you can't use it, as here, and sometimes you shouldn't use it because an alternative design is better, statistically. So far, the Protector study has demonstrated acceptability of this new two-step operation, as well as benefit on sexual function and quality of life. However, the actual level of ovarian cancer risk reduction this operation likely confers remains unknown. So we've been helping to advise how this study could be extended to provide evidence to assess this latter objective here. To do this, we've worked with the Protector team to consider different alternatives, including at a collaborators meeting earlier this year at Charterhouse Square, where we've had a lot of input and broader discussion. And I'm now going to hand over to Emily, who has been crunching the numbers and will discuss some of the design issues we considered and our recommended approach.
Thanks, Adam. The first design option we considered was the same approach as in a Dutch study called the TUBA-WISP-2 study, investigating whether the removal of fallopian tubes followed by the delayed removal of the ovaries is non-inferior to the removal of tubes and ovaries at the same time for prevention of the ovarian cancer. Technically, this is called salpingectomy with delayed oophorectomy versus salpingo-oophorectomy. Always hard to get that out. For patients choosing to have their fallopian tubes removed prior to their ovaries, it was assumed that fallopian tubes are removed any time before the age of 40, and ovaries are removed any time after the fallopian tubes between the ages of 35 and 40. In patients choosing to have their fallopian tubes and ovaries removed together, surgery is performed at any time between the ages of 35 and 40. And depending on BRCA gene mutation, participants are followed up until they exit the study at ages either 45 or 50. This design aims to test whether the incidence of ovarian cancer in those who intend to have their fallopian tubes removed before their ovaries is non-inferior, meaning no worse than, in those who have their ovaries and their fallopian tubes removed together. Therefore, the difference in ovarian cancer incidence between the two groups needs to be estimated. We expect that most cancers will be detected at preventative surgery, meaning that occult cancers detected prior to surgical intervention has taken place or has had any effect, and cancers detected after patients in both arms have had their tubes and their ovaries removed, we used to power the test of non-inferiority. With this study design, where the clock is started and we start considering cancers detected before salpingectomy and delayed oophorectomy, we're more likely to conclude that salpingectomy and delayed oophorectomy is non-inferior to salpingo-oophorectomy than if we started the clock after surgery. Therefore, the study design is biased. An alternative design is to simply start the clock after surgery and do the same comparison. Unfortunately, in practice, this study design is infeasible. The power of the study depends on the number of ovarian cancers diagnosed during the follow-up period in the two groups. Starting the clock after surgery to test non-inferiority is practically infeasible because we expect very few cancers to be detected in either arm after surgery. We estimated that this design requires 27,500 participants to achieve sufficient power, which is not feasible given that the Protector study only has capacity to recruit up to 30 patients per month. Therefore, we recommended not to use this design. Finally, after reviewing a number of alternative designs with Ranjit and his team, we recommended a one-sample design. This design compares the observed number of cancers detected after salpingectomy surgery, which is removing the fallopian tubes, to those expected number if there was no surgery. Follow-up starts after surgery and ends when patients experience menopause. The power calculation and expected number of cancers account for a lead time, as it is expected that almost no cancers will be detected in the first 18 months following surgery. A required sample size was determined by simulating the study thousands of times under various assumptions of risk reduction and follow-up using an adapted version of an ovarian cancer risk model called Boadicea, and other assumptions based on the patient demographic information of participants already recruited to the Protector study. We calculated that the required sample size was 1,150 patients.
Thank you, Emily. So in conclusion, the aim of this talk was to give you a flavour of what we can do at Barts CTU in terms of helping to advise designs. We're particularly interested in developing long-term partnerships, such as we're building with Ranjit and his team, not only on this study, but on other precision prevention studies they're running. Ultimately, to generate better evidence to build a healthier, better world as our central objective. Thanks very much to Ranjit and the Protector team for their support, and thank you for listening.
Thank you, Adam and Emily. I think that rounded up session 2 quite nicely, and you've got an overview of the work some of the work that we do in the Barts CTU.